Welcome back, everyone. We're into our last session now for this part of the symposium, and it's a great pleasure for me to welcome Professor Shinichi EGAWA. Professor EGAWA is a clinical pancreatic surgeon in his daily life, but he also is a professor of disaster medicine at Tohoku University in Japan. He was appointed after the 2011 Great East Japan earthquake, which we are all familiar with, and he has dedicated himself to bridging the gaps between disaster medicine and the other important fields that are involved in disaster response, and between the health aspects of it and other disaster risk reduction clusters. He is extensively published. He's published more than 180 papers in the English literature and countless more in Japanese, including the World Health Organization Guidebook for Health, Emergency and Disaster Risk Management, which is something we're working very closely with him on at the moment. So he's going to talk on two topics today. First one is on the Dmad system in Japan. We'll take that topic first and do any questions from that, and then we'll switch on to the second topic after that. Shinichi, thank you, and all yours.
Thanks. Thanks, Colin, for kind introduction. And this is a great pleasure for me to be here. And I'm going to talk about the Dmad system in Japan today. And so you can see the slide well. Okay. Then I have no conflict. And let me introduce something about the very conceptual things about the disaster risk reduction and the other disaster medical system in Japan supporting the Dmad system. So the disaster risk factors are the vulnerability and capacity, and the earthquake, storms, and tsunami or radiation, biological hazards. These are called hazards. They are not disaster by themselves, but when they attack the community, which has some vulnerability and coping capacity, the outcome or consequence is the disaster, loss of life, properties, and community. And these are the chemical hazard. This one is a saline, a nerve gas, toxic gas, and this is familiar with the SARS-CoV-2, the virus. So when you want to reduce the disaster risk, it's a simple equation. So the risk is calculated like as hazard multiplied by vulnerability divided by capacity. So when you want to reduce the risk, make the hazard and vulnerability smaller and make the capacity larger so that the risk can be more smaller. And the disaster medical system in Japan, and I published this chapter in the WHO guidebook on the research method of health and disaster risk management. So you can download this for free from the website of WHO Kobe Center. And this is a history of Japan, earthquake and tsunami, and the history of other disasters in Japan. So when you look at the 1960s, this is an enactment of the Disaster Basic Count Act in Japan. And while there was a little bit smaller number of disasters after that. But this 1995 was a remarkable year to build up our disaster medical system and the establishment of the Japanese Association for Disaster Medicine. And this city is Kobe. And the Kobe was attacked by the magnitude 7.3 earthquake, and the many houses and buildings were collapsed, and a number of people died of asphyxia, just crashed by the collapsed building. And so the life-saving ideas from the past disasters is the legal enactment of building codes for earthquake proof to prevent death from fire and collapse, a national establishment of disaster medical management, and early warning and evacuation. But today I'm going to talk about this one. Okay, so the disaster medical assistant team, Dmad, Japan has more than 1,000 teams throughout the nation, And Dmad are expected to arrive in the affected area within 24 hours and save the lives from preventable death until 72 hours when the local healthcare recovers. So it was expecting a little bit shorter duration of the lag between the previous medical system and the recovery of the local healthcare providers. And the Dmad consists of a medical doctor or at least 2 nurses and a logistician with self-standing materials and vehicle. And specific training for confined space medicine was provided. And there are 2 tiers in the Dmads. The first tier is a Dmad registrant, and they must complete the standardized training course provided by the National Disaster Medical Center and is registered with the Ministry of Health and are qualified as Dmad team members to be dispatched to the scene of disasters during the acute phase. And the second tier is a Dmad supervisor. They should have experience as Dmad registrant and has advanced knowledge of Dmad operations and is accredited by the Ministry of Health and plays a guiding role in Dmad team member training courses and directs the Dmad operations, and they can be the disaster medical coordinators. And this is a picture of the Dmad standard textbook, and the first edition was published just 1 month before the Great Eastern Earthquake in 2011. So that a second edition was published like 4 years later with updates from the 2011 earthquake. And Dmad team member training course takes 4 days, and it takes 2.5 days if the participant is already qualified as a prefectural Dmad. They should have another similar 1.5 or 2 days education to become the prefectural Dmad. And the Dmad supervisor training course takes 2 days. So the 1 team, 1 doctor, 2 nurses, and 1 logistician. So that these are typical picture of the Dmads. So that they should be able to accommodate it in the 1 car. And they are training the staging care unit and for the wide area transportation. Staging care unit means the triage or prioritizing the severity of patients to be dispatched to the distant area or not. And the Dmad member has a rule to follow. So the CSCA TTT was adapted from the MIMS system from the United Kingdom, and they work as a regular healthcare workers, but if something happens, they can be dispatched by the order of prefecture and follow the rule, this CSCA. Okay. And there are other systems that are supporting Dmad to be able to operate in a time of disaster. So there are more than 700 disaster-based hospitals in Japan, 1 national disaster medical center, and these disaster-based hospitals are providing Dmad. And they have the emergency center because they are usually serving to the community as a tertiary or at least secondary or majorly tertiary hospitals. And there are 54 radiological disaster-based hospitals that will respond to the nuclear or radiological disaster. And these disaster-based hospitals serve as the tertiary hospital, and national health insurance system make this possible. So that disaster-based hospitals should have emergency room, but the capacity of being headquarter, the Dmad provision, and they have the emergency infrastructure with waters, oxygen, and power. And recently, it was mandated that they should have business continuity plan, BCP. And these are the aircrafts used in the disaster medical response in Japan. But even the biggest one can accommodate a small number of patients. So the prioritization of the patients to be transported is a very important issue. And this is a disaster emergency medical information system called EMIS. And this is an actual scene of the Kumamoto earthquake in 2016. So you can see the actual location of which Dmad teams are in which area of the disaster affected area. And you can see the where is a disaster-based hospital, and where is other clinics and hospitals, or where is the evacuation center, and they can share the information through this system. And so this is a picture of before March 11, the Great East Japan earthquake. The National Disaster Medical System was established before the GEJE under the control of Ministry of Health, Labor, and Welfare. But I'm going to show the reality. So in 2011, March 11, the whole Japan was shaken by the magnitude 9 earthquake. And this is a simulation. This Professor Imamura is a director of IRIDIS now, and he is a tsunami scientist, and he created the tsunami after the disaster happened. So it takes like 30 minutes for tsunami to arrive to the coastline of the Tohoku area and up to the Kanto area. The whole length of the south and north is like 500 kilometers. Okay, I'm skipping this. And as you know, this is after the explosion of the nuclear power plant. So this is a triple disaster: earthquake, tsunami, and nuclear power plant accident. In response, the more than 300 Dmad teams, 800 members were dispatched throughout the nation, so that they came to this airport and this airport using the aircrafts. But not only the Dmad, other medical assistance team like National University Hospitals team, Japan Red Cross Hospital teams, Japan Medical Association teams, and other NGOs, including the one international medical assistance team. So that when the nuclear accident happened, this D means the decontamination area. Dmad served the supervising of the transportation of the affected people to the non-contaminated area. But unfortunately, these hospitals, the doctors and nurses and the bedridden patients were forced to evacuate in a cold weather. And there are 45 deaths during the transportation. Dmad helped, and after Dmad intervened, there was no death related to that. And this graph shows the contaminated area throughout the Japan. Okay, but this, the red area is relatively small, I think. So this is back to the actual disaster. 1 month later, the contamination area, but even 5 years later, there are some high area. But the Dmad teams faced the difference of the medical needs in disaster. In 1995, Hanshin Awaji earthquake, the magnitude was 7.3, but the injured number of patients injured was 43,000, dead and lost 6,000. But the magnitude 9 Great East Japan earthquake, which is 350 times stronger than the Hanshin Awaji earthquake, resulted in the 20,000 people of death, but the number of injury was remarkably decreased because of our anticipation and preparation for the quake-proof structures. But different medical needs lasted longer. Disruption of traffic and communication made the health sector paralyzed, and complicated radiological disaster made the situation complicated, and mental health of affected people was devastated. Health facilities were also destroyed by disaster. And the education of disaster medicine, including me, was not generalized in health professionals. But when we had the aftershock of this great magnitude 9 in this year, the February 13, there was a 7.1 magnitude earthquake happened on the same area, but there was no dead and lost. So this is another remarkable improvement. So that when something happens, the disaster medical needs and or public health needs changed like this. Injury may be a very rapid phase, and the non-communicable disease will follow. And the infectious disease depends on the situation of sanitation. But the low capacity of the local health providers remarkably declined and will recover lately. So the external relief aid is a must. But the people should help themselves until some help arrives. And this is a statistics of the one single town. But this town lost all medical facilities, including clinics and hospitals. So those people, 10,000 people had symptoms reading the infectious respiratory disease, hypertension or metabolic disease, diabetes or hyperlipidemia, or polynosis or orthopedic diseases. So these type of non-injury medical needs were the main cause of the medical needs in the evacuation centers and towns. So the transition of the number of people or number of diagnoses of the non-communicable disease changed like day was a peak, then day 10 was a peak and gradually decreased. Or infectious disease also decreased. But this is a fortunate outcome because there was no recurrent outbreak of the infectious disease. And mental health issue had a similar tendency. And the trauma, these trauma are not trauma by the great the direct shake or tsunami, but the trauma related to the clearing of the debris. So the number of evacuation, at the peak time, more than 400,000 people were evacuated in total. And the Fukushima prefecture suffered more than 30,000 people still now. And this is a typical phenomenon after the Great East Japan earthquake, the disaster-related death. So the number of people died not directly from the tsunami or shake, but died because of the fatigue during the evacuation or transportation or mental health disease, including the suicide. And another typical feature is the number of hospitals was damaged by the tsunami, and they had to be evacuated from its location. And some of them were stopped already, the medical services. Some of them were relocated like more than 5 or 7 years later. Another problem is confusion of the large number of help voices and large number of relief aids. So the coordination between the relief aids was a problem. So the improvement after the Great East Japan earthquake, I think I don't have much time to say all, but the change, I have to describe the change of Dmad. As I said, the coordination was a problem. So that the increment of the prefectures after the Great East Japan earthquake, which assigned the medical disaster medical coordinator, was dramatically increased after the Great East Japan earthquake. So that now the Dmad system in Japan looks like this. So that Dmad is supporting the disaster-based hospital, also support the affected local hospitals. Okay, thank you. And they are coordinated by through the EMIS, the information system, and someone transport to the distant area, and the distant disaster-based hospital also plays a role of accepting the patients. So the Health Resilience Society is the conclusive message. So every disaster is different, but affects the health of people, and the role of disaster medical personnel, including the Dmad, is very similar. And the disaster risk reduction framework, know your risk and reduce your risk and be prepared to act, is a key backbone. Disaster risk reduction is not achievable without health promotion of the society. So the helping only in disaster is nonsense. So help the vulnerable people, even in peacetime, is a must do what to do. And Japan is continuing to build back better after disasters, including this GEJ and also ongoing the COVID-19. So please understand that the Japan Dmad has the capability and flexibility to support local health providers. It is now being the main goal of Dmad. Thank you very much.
Thank you very much, Professor EGAWA. We don't have any questions from the audience just yet. I suspect they're still taking in just the enormity of the disasters that you're describing. I mean, I've got a couple of questions. I mean, if you had to give us the one biggest lesson for the Dmats and the Dmat system after the tsunami, what do you think that would be?
You know, the Dmad was first established to save the life of preventable death in preventable disaster death, because when 1995 Hanshin-Awaji earthquake, number of hospitals were suffering to who should save and who to which we can prioritize the medical resource, because in disaster the medical resource is so small compared to the large demand. So the lessons in 1995 was how you can save those disaster preventable death. However, after the Great East Japan earthquake, the injuries, including the crash syndromes, those number of injuries were not so much large compared to the number of non-communicable disease or mental health problems. So that we should confront to the change of medical needs in disaster in every time. So that COVID-19 is also create the same situation. So the general people are thinking that COVID-19 is a matter of medical people, but that is not. That it is now becoming the all-out war.
Absolutely. Yeah. Can't agree more with that.
Lesson.
Yeah, I can't agree more with that. I mean, that ties in with my second question, which, as you said, I mean, you've got to learn from every event and every disaster. But you know, we mentioned earlier in the day that between Hong Kong and Japan, we fight every year for who has the longest life expectancy now, as our populations both age and continue to age, and with that brings all the chronic health conditions that you mentioned. I guess my question is, there's a tension there between training people to manage trauma and on the same hand training them how to deal with the early management of chronic health like hypertension and diabetes. You know, teaching a surgeon to manage diabetes and teaching a diabetologist to do an operation are two entirely different sides of, obviously, of a common coin. But do you see tension in that when you're training the DMATs in real time?
Thank you. And actually, I have to confess that I am not a member of DMAT at all. I am a general surgeon specialized in pancreas. That is meaning that I am good at managing the older people facing the metabolic syndromes and also the suffering from the pancreatic defects, include the nutritional deficiencies and chemotherapies and the other way of thinking of the mental health of the terminally ill patients. So that when the 2011 GEJ happened, our hospital director ordered all of the university hospital physicians to be a primary care physician, so that you can do something for the people who is suffering. And if you do not think that you are suitable to treat that patient, why don't you convert or refer to experts for that reason? But it is not necessary for the all experts should go out to relieve the affected people. So that the Dmad and other disaster medical relief teams in Japan are trained through the CSCA TTT, so that the assessment of the situation and the triage will make it easier to focus which patient should go where, so that the transportation to the resource-rich area is a first key issue for the medical assistant teams. Do not treat the final treatment in the disastrous situation. That is a key message in the textbook.
A guiding principle. And just to finish off, my other question is, I mean, and this may be just my lack of knowledge of how the Japanese system works, but you mentioned doctors and nurses, and obviously the incredibly important contribution of logistics experts in the Dmad. You know, in places like Hong Kong and obviously in the West, we have paramedic staff who are far more experienced at aspects of pre-hospital care compared to the system in Japan. Do you see a role for them in your setting, or is it going to really still be doctors and nurses? Because certainly in Hong Kong, we would never be able to find enough doctors to do this kind of thing.
Mm-hmm. And it depends on the local context or a national context of how the nationwide disaster medical system was established. And I think the health insurance system is different and the medical system is different. So the two systems should be different. And I think that this is a good connection to the next speech, so that the paramedics and the firefighters can contribute to our disaster medical system. But in Japan, the emergency, the paramedics or lifesavers in the ambulance are playing the important role to transport the critically ill patients to the hospitals. And when the disaster happens, it is not easy to transport from the directly affected area to even to the local hospitals because of the congestion and the road conditions. So that we have to have the disaster headquarters will collect all the information of the transportation and how many ambulances are available, or how many helicopters are available for the distant area transportation. Kind of things are concentrated to the headquarters, so that every stakeholder can play an efficient role. These are the very key issue of the medical coordination by Dmad and other medical or local governments of Japan.
Excellent. One final question from the audience, and I'm grateful the audience is obviously still listening closely. The question is, in the future, can we develop disaster medicine as a preventive measure in order to try and minimize the impact on health and medical services?
Yes, of course. So that the preparation is more cost-effective in the field of disaster risk reduction science. So when you spend $1 for the preparedness, you will save more than $5 or $7 for the response. So that the many hospitals were devastated by the tsunami. So if you can anticipate the future tsunami affected the area, so that the building a hospital for the higher area is a good risk reduction, and will spend a lot of money that should be spent by the loss of hospital. So the most expensive hospital is a hospital without a disaster risk reduction plan. So planning is important, and that's the reason why the national government enforces all disaster-based hospitals, the PCP.
Perfect. Thank you very much.